Hi everyone, my name is Allison Schachter. I'm a senior associate at Ideas 42, and today I'm excited to talk about the design and results of our project focusing on the provider provision of respectful maternity care in Zambia. The project was implemented under Breakthrough Research, a 5-year USAID-funded project focusing on social and behavior change research in health and development programs around the world, and led by Population Council. And a bit about us at Ideas 42. We use insights from behavioral science, and that's a collection of academic fields such as economics, psychology, and neuroscience that provides insights about how and why people behave the way they do. We use these insights to design solutions to some of the world's most persistent social problems. In our efforts to focus on improving provision of respectful maternity care, we completed a 4-phase process based on a behavioral design approach. And in collaboration with our local implementing partner, Sat Motherhood 360 Plus project and the Chipata District Health Office. We first defined our provider behavior focus, and then conducted formative research to better understand the barriers and channels to that particular behavior. We led a co-creation process to develop solutions, and then piloted those solutions and evaluated their effectiveness. And so that first step was to define our behavioral problem of focus. And that was that providers do not consistently follow best practices during delivery, especially those related to respectful maternity care. And so we conducted formative research to better understand why and what those behavioral barriers were. The first theme that we found was that harsh treatment is normalized in the clinical setting. And when providers engaged in disrespectful care, there were no consequences. Midwives often experienced violence as children, leading them to default into harsh treatment as a disciplinary tactic. And on-site training reinforced harsh treatment as a means to achieve client compliance. There's no clear way for clients or peers to create consequences for providers who engaged in disrespectful care. We also found that providers focus on death avoidance over everything else and other things that you might consider for quality of care. This was reinforced in trainings, supervision, and feedback, which focus on clients and infants for survival almost exclusively, and also was reflected in the visual cues in the physical space. Midwives received no salient information on feedback and on the impact of disrespectful care on health outcomes, which are their primary concern. And last, the pain of labor and the implications of being in pain is part of the challenge. The pain of labor will have a negative impact on a woman's experience in a very direct way. But also, as women were not supported during delivery or received pain management, they were less likely to feel trust and rapport, and in some cases follow instructions. Providers would describe this, quote, lack of cooperation as a justification for being harsh. Midwives believe the pain of childbirth is inevitable and have limited strategies to alleviate it. And so based on these formative findings and our better understanding of the behavioral drivers of care, we then designed a 5-component solution package to address these barriers. And the first of which was a pain management toolkit, using the mnemonic of BETTER, which stands for different pain management techniques that providers can use. The toolkit consisted of posters, which were visible to both providers and clients, a manual on the different techniques and how to use them, a cartograph guide, which prompts providers to specific pain management techniques at different stages of labor, and massage balls, which could be used to provide pain relief. And the way in which the toolkit worked was that it first frames pain management as part of the routine clinical care. It elevated pain management as a part of this clinical care and incorporated it into the provider's current priorities and how they think about their role. It expanded the choice set for providers to include additional evidence-based techniques. The toolkit cues providers to offer pain management so that it's top of mind for providers. It also addresses power dynamics by prompting the provider to be in service of a woman and by inviting the woman to increase her expectations and ask for pain management support as well. And lastly, it addresses common trigger to disrespectful care we identified in the formative research. The toolkit further humanizes the relationship and builds rapport between patient and provider by prompting a repeated and caring behavior. And next, we introduced a provider-client promise, which serves as a commitment device and was conducted upon admission to the labor ward with each individual client. It outlined the expectation and promises for both the provider and client. By setting expectations for both provider and client, it addresses power by elevating patient expectations and including items she should expect that she previously did not, such as pain management and support. It also set boundaries for what is considered acceptable for the provider, develop rapport and trust amongst providers and clients, and also invokes a feeling of dissonance if a provider considers behaving in a way that contradicts the promise. Behavioral science tells us that saying something out loud, even if there are no consequences, has a tendency to instill a sense of commitment, and we will avoid behaving in a way that contradicts that agreement. We also implemented a feedback box. Clients were provided with a token upon discharge, which they could then insert into one of 3 slots to indicate their satisfaction with the service they received. The box was placed somewhere that was both accessible to clients, but out of sight of providers so that women could privately provide feedback. And the box worked in that it elevated the importance of client satisfaction. Feedback focuses on clinical outcomes, and usually client satisfaction is less salient measure of performance. It also empowers clients to share feedback by proactively prompting patient feedback. Patients receive the impression that their experience is valued and they have a means to address their concerns. We also held a reflection workshop. It was delivered to providers at the onset of the intervention and included sessions which set out to encourage providers to reflect on current care, both from the perspective of women and providers, and also build empathy and instill a commitment to a change. It allowed providers to generate a dialogue on client cooperation and best practices, and it ended by providers reaffirming their commitment to providing respectful care. The workshop was also the channel for introducing providers to the other interventions. And lastly, we introduced Fresh Start funds. Each facility was provided with a small fund to make changes that would positively affect the non-clinical client experience. And that was in part to promote a sense of agency and motivate positive change amongst providers. And it also signaled a fresh start both for clients and providers about the care that they would receive and provide at the facility. And so once we designed these 5 solutions, we conducted a quasi-experimental evaluation in late 2019. We identified 5 facilities in which we implemented these solutions and 5 which would serve as our comparison sites. We collected baseline and endline data, both with clients and providers, conducted observations in the health facilities, as well as interviews with health facility managers. And we identified 3 key takeaways. The first was that clients at intervention facilities were less likely to report disrespect at endline compared to clients who delivered at the comparison health facility by 15 percentage points. We also saw improvements in pain management support. Clients at intervention facilities were more likely to request pain management during labor, and providers at intervention facilities were more likely to rate pain management as one of the most important tasks during labor and delivery. Descriptively, we saw a shift in the types of pain management techniques used by intervention providers at endline, and included things such as massage, breathing exercises, and change positions were commonly cited, all techniques that were included in the Better manual. And third, providers at intervention facilities were more likely to be empathetic towards clients. And speaking with health facility providers and in charges, we found that the providers found them designs easy to implement without significant investment of resources. Our experience implementing the designs in Chipata demonstrate the potential for behaviorally informed solutions. I encourage you to visit the Breakthrough Research website for our briefs, outline the findings from the pilot, as well as more information on our implementation experience in greater detail into our behavioral insights. Thank you so much for your time.
Hello everybody, my name is Alice Janvrin and I'm here with my colleague Gillian McKay, and together with Dr. Benjamin Black we are here today to present an assessment we did on the impact of Ebola on SRH. So to situate you in the context, we did this work during the 10th outbreak of Ebola in the Congo, which went from August 2018 to June 2020. And hysterectomy if they hadn't been the triage, and we would have evacuated the uterus and left it there. So this really shows the impact of the Ebola policies on some of these pregnant women. So now passing on to my colleague Gillian next to me.
Thanks, Alice. So as part of our assessment, we also looked at family planning. So what we found was that many women and their partners very much expressed a desire to delay pregnancy during the epidemic. And this was for a variety of reasons. It could be because of the economic impacts of the outbreak, or it could be because some of the women had heard about cases of their friends or family members who did not receive appropriate maternal care during the outbreak because of the policies of the Ebola outbreak. There were also quite varying views among women, so family planning users, as well as healthcare workers, on whether side effects of family planning, which, as many of us know, can often cause breakthrough bleeding, are considered explained or unexplained, and therefore might necessitate an Ebola test before appropriate treatment can be given. It appeared as though people, healthcare workers who were more familiar with family planning delivery and supply were less likely to consider this an unexplained bleeding and therefore potentially have to send these women away for testing. And this is a great quote from one of our male participants in the research, that Ebola time is a good time to plan your family. As relating to abortion care, the general discussions that were had were around the challenges of spontaneous abortion rather than access to safe abortion services, and women's real fears about being isolated at triage if they arrived with kind of having had an abortion potentially at home and requiring additional treatment for post-abortion care, but being unable to access that because they had that unexplained bleeding. Since this kind of again shows that sort of unexplained bleeding versus explained bleeding are very create a huge amount of tension in clinical decision making in an Ebola context. Another quote here: since the start of the epidemic, all bleeding is a suspect Ebola case. Even when it's an abortion, if you induced your own abortion, it's a suspect. The recommendations from this research were not short. There's a fair few of them, but they can all be read in depth in the report that you can find there if you just Google "not all that bleeds is Ebola." But our key ones were that sexual and reproductive health considerations must be embedded in the Ebola response from the very outset. This is a must-have, not a nice-to-have. And the main reason for that is for number two, work to reduce delays at every stage of the patient journey, specifically harking back to what Alice said about the 5 delays model. It's very important as well to support individuals and communities to mitigate the risks posed during and after an Ebola epidemic as relating to their sexual and reproductive health. And to formulate guidelines with sexual and reproductive health and Ebola expert involvement. What we've found in our experience is that these guidelines tend to be written either by Ebola experts or by sexual and reproductive health experts, and therefore there's a lot of nuance that's missed in the translation. We felt it was important in this context in which we all find ourselves to draw forth any potential lessons for COVID-19. Now, the most important lesson, maybe first off, is that COVID-19 is not Ebola. The transmission is very different, the symptoms are very different, the impacts on maternal health can be very different in terms of kind of confusion between COVID and reproductive health complications. However, we are seeing some decisions and policies that would probably usually be applied in an Ebola outbreak, but probably wouldn't be required in a COVID-19 pandemic. And an example of this is in the Bangladesh Cox's Bazar Rohingya camps, where there's very large COVID-19 specific facilities being built specifically for COVID. A woman in labor with any signs potentially of COVID can be sent to these facilities, delaying her access to sometimes very needed obstetric care if she's in labor, where these facilities don't have that kind of specialized services, meaning that she's losing access to very important service. That being said, a number of the lessons from our report from Ebola in general do still apply. That sexual reproductive health care is still very much needed in the COVID-19 outbreak, even more so in cases where, for example, girls being out of school, losing that protective influence, having a possible increase in unintended pregnancy. The loss of trust in healthcare systems due to COVID-19 can increase delays in care seeking due to fear of contamination or decreased quality of care. Screening procedures can cause unacceptable delays in provision of essential time-sensitive care, and this is where a rapid test, when it's available, will make a really big difference. And making sure that those guidelines for sexual and reproductive health in COVID are made jointly, not in silos. So thank you very much. We're going to end it there with special thanks to everyone here, and thanks from us. We look forward to your questions.
Hello everyone, my name is Imani Akiza Marie Louise. I work for Partners in Health in Shutimu Uzima, an international organization working with different countries, including my country, Rwanda. I'm a nurse and I have a degree of bachelor's in public health. I have been working with public hospitals in their neonatal intensive care units past 5 years before being a mentor with All Babies Count intervention, and currently I'm a program manager at Partners in Health in Shutimu Buzima in Rwanda. Today I'm very happy and delighted to be with you. I'm very proud to present our paper about quality improvement strategies to improve the patient management of small and sick newborns across all babies count supported hospitals in rural Rwanda. All babies count is an integrated model to eliminate preventable newborn deaths and an 18-month change acceleration process intervention that provides neonatal equipment and supplies, provide neonatal training and mentorship, and the district-wide learning collaborative sessions to promote peer-to-peer learning among health professionals and promote their continuous quality improvement. Why all babies count? This is an immense opportunity to prevent neonatal death by improving the quality of facility-based care, whether preventive, curative, and transformative. By curative, we mean caring for newborns experiencing complications and caring for small and sick newborns at hospital level. Whether transformative, by promoting a culture of data use for continuous quality improvement. This study has been implemented at 7 rural district hospitals, but before was piloted into 2 hospital catchment area in eastern Rwanda, and this study looks only at the scale-up of all babies count additional 7 district hospitals across the country, as you can see mapped on this map in red cross. This study was a pre-post quasi-experimental study conducted in 7 rural district hospital neonatal care units that received ABC support in a period of 2 years from 2017 to 2019, with the data of baseline collected from April to June and from July to September, depending on the startup of the project at each site. Data collected included facility audit of equipment, supplies, and staff, mentorship reports, learning collaborative surveys to assess providers quality improvement skills and their confidence in quality improvement, and some additional data like neonatal mortality and number of admission have been extracted from the National Health Management Information System. As the result, in about course improvement skills, there have been an increase in all NICU providers or staffs across all skills from aim statement, throughout developing and testing change ideas, using PDSA cycles, and to using quality improvement statistics to track their progress in their quality improvement projects. As you can see on the above this chart, the arrow in green represents the data on quality improvement skills of staff in the learning collaborative sessions, and the data in orange represent quality improvement skills of staff in the fourth learning collaborative sessions. About the result on change ideas, the NICU staff developed change idea from the gap that they was having in providing quality of care in their facilities, but almost all hospitals developed change ideas aiming to improve adherence to neonatal care protocols. About 85.7% focused on improving communication with families of patients, 71.4% focused on regular vital signs monitoring. Others worked on their own teamwork approach and promoting family engagement in care, but also there are some hospitals worked on monitoring and adjusting neonatal feeds. What about the result on outcome indicators? Admissions increased over the implementation of this project from 121 to 137, but also overall case fatality rate decreased from 12.4 to 7.8, and case fatality rate among premature and low birth weight decreased from 18.4 to 11.7. As you can see, data highlighted in bold. We are very, very proud of this intervention and their huge improvement during implementation phase. As lesson learned, the All Babies Count package of intervention was associated with significant neonatal mortality reduction and service utilization in the intervention hospitals. As you know, uh, for reducing neonatal mortality or neonatal death, it requires high resources, either human resources or other financial resources, but this intervention worked only with staff and working with quality improvement strategies to improve gaps in their performance. And the strategies, quality improvement strategies designed by health facility quality improvement teams formed at the beginning of implementation of All Babies Count shows practical, feasible strategies for replication by facilities facing similar quality gaps. I thank you all for your kind attention. Thank you for All Babies Count and partners in health, and thank you for all staff participating in this intervention. Thank you for a GLOW conference organizers to give us this opportunity. Thank you for all.
Great, thank you to all our three presenters for those really great presentations on really different pieces of work, but all very important. So we'll just have a, maybe for another 15 minutes, just a question and answer session, just to really try and engage with the speakers to explore a little bit more about their work. Maybe Alison, I'll start with you. Really important piece of work in terms of really finding out what the underlying factors are for providers not really engaging with providing respectful maternity care. And I guess one of the things you said was that some of them had experienced it all their lives. You know, it's the norm in terms of, you know, how you try and enable or support mothers to adhere to the instructions that they're giving. One of the things I was interested in was the issue around providing funds towards trying to support the change in behavior. And so I guess in terms of implementation research, we want to be very, you know, as much as possible, try and ensure that whatever we are doing is implementable and sustainable. So my question, you know, for that would be, if you introduce money, so you're giving money towards, you know, an implementation program to enable it to happen, isn't that introducing a little bit of a parallel program into those institutions, and that will then prevent them from, you know, being sustainable in the absence of that funding?
Sure, thanks, Helen. I think that's a great question, and I think you're referring to the Fresh Start funds, which, to just speak a bit more about them themselves too, they were a very small pot of money, and they were really to create signals of non-clinical changes at the facility rather than clinical changes. And interesting, that was really to spur momentum, to engage the providers. And we actually, of the designs that we implemented, we found that these actually were those that were less necessary to see the change that we ultimately saw. Providers already had a high sense of agency and were engaged and wanted to make change. And so we found that the Fresh Start funds, which were intended to really spur momentum and enthusiasm around the project, may not have necessarily been required in this context because there was already that high sense of agency. And they were, to iterate, they were a small amount of funding. It wasn't anything extravagant, really just to, you know, freshen up the facilities and visually demonstrate that fresh start.
That's great. That's great. So I guess in that way, issues around freshening up a facility, for example, if you want to engage in research in that facility, I guess that points towards the partnership that you developed with, you know, the local partners, the Ministry of Health, where you're supporting them with, you know, infrastructural improvement somewhat so that you can conduct your research, but also for the benefit of all patients who use those facilities. That's great. So again to you, Alison. So in terms of, obviously you gave us a lot of background information about what, you know, what the norms were. We know that you achieved a change. It must have been very difficult. Could you just talk us a little bit through that process? Because obviously from having people who've grown up, you know, knowing, you know, this is the norm, to having a series of workshops and then suddenly changing that behavior, I'm sure it did happen over, you know, a few sessions. Was there mentoring, was there support, supervision, or anything like that that was attached to that implementation program?
Sure. So the reflection workshop was actually a one-time engagement with the providers, and that's where we focused on that values clarification, that empathy building. It provided an opportunity for providers to reflect on, you know, their own experience, both personally and with their interaction with clients, to make a commitment to respectful care, also involved role playing and more engaging activities. And following that workshop, the development of empathy was much less about priming providers to think about empathy, but more so about creating a repeated and caring behavior. And so by repeating those caring behaviors, both through the pain management toolkit, through the provider client promise, building empathy in that way, so that it was less explicit or priming them to think about it, but more so in their then repeated behavior through the use of the different tools.
Okay. So I guess, Gillian, it's a question, I guess, that merges a little bit with what Alison had talked about in terms of how you incorporate sexual and reproductive health priorities in responses to, for example, the Ebola outbreak or the COVID-19 outbreak. Just wondering about the process, how you'd engage the relevant stakeholders appropriately to ensure that that is included in policy earlier on, as opposed to an afterthought. So this is a question for Gillian.
There we are.
Yes, now we can. And sorry, Gillian and Benjamin. Thank you.
Hi, Liz. Thanks so much for the question about prioritization and kind of engaging stakeholders. So it's really about engaging the MISP early on in the response, the minimum initial service package. So the MISP in the past hadn't really been designed for outbreaks. It was much more for displacements and other sorts of humanitarian crises. But I think what we saw in the West Africa outbreak, and definitely in the DRC, is that Ebola responses tend to be run a little bit in a siloed fashion. And it's very important to consider that you have a wider humanitarian crisis happening outside of the executive health response. So working very closely with Ebola response leadership to ensure that any disruptions that are going to be caused as a result of Ebola policies and or COVID policies, whatever they might be, are mitigated. Do you want to add anything, Benjamin?
Sure. So maybe I can just add to what Gillian said. You asked specifically around the prioritization. One of the issues that we found with sexually reproductive health work, particularly in humanitarian emergencies, is that you can't separate the status of sexually reproductive health engagement from the status of women within the society that we're trying to engage. And so that has to go hand in hand with what we're trying to do and trying to make the needs of sexually reproductive health within the population impacted, for example, by an Ebola epidemic, or as you mentioned, COVID-19, has to go alongside ensuring that the status of women within that society is also being acknowledged, because they do work together. And secondly, as Gillian sort of alluded to, there is the difficulty that we face within particularly outbreaks of disease, that the health focus becomes quite tunnel vision, and that everything becomes moved towards what is perceived to be the emergency at that time, which might be the Ebola outbreak. Whereas we know that more women are going to die from complications of maternal causes or other sexual reproductive health causes than they are going to die directly from having Ebola or from having COVID-19.
That's right. And I guess one of the interesting things between your presentation and Alison's was the engagement, I guess the involvement of the recipients of that care. So, the clients or the patients. And I just wonder whether you could speak to how they can be involved in that process of prioritization during these emergency responses. So obviously, you stated quite clearly the collateral damage, the issues around, girls being out of school and things like that. So how can we, as implementation researchers, push for them, their voices to be heard in this process?
That's a great question. And I think a big part of it does come down to really solid community engagement and really solid social science being done at all stages, from the very start of the response onwards, and asking those tough questions about, how is this impacting you and what we need to do differently. But also, I think a big part of it is that, women need to be involved at all levels of the response. And often, and I'm not saying this is a criticism, but a lot of time these responses are quite male-led. So it's very important to have women from that country and from the region involved at all stages, because they do bring a different set of questions to the table, especially at the strategic level, I think.
Yeah, I think, I think it's interesting. I like that your question you ended with asking us how they can be heard. Because I think a big part of it is making sure that we're listening to communities and engaging with them, hearing exactly what are their concerns, rather than assuming on their part what are their priorities, what are their concerns. If we don't hear what they have to say and listen to what they have to say, then it's very difficult to tailor our response in a way that they're going to want to engage in a way that's useful for them.
That's great. Thank you very much. So Marie-Louise, I hope you're still there. Can you hear us? Marie-Louise?
Yes.
Fantastic. You can see. Can you hear us?
Yes.
Welcome. So the next question is really directed towards you. You really showed us some excellent improvements, policy improvements that have taken place in Rwanda with this project that has been implemented to address the high numbers of deaths amongst newborns in Rwanda. So I guess the question is, with all these really great results, how is this process going to be sustainable? What measures have been put in place beyond the study, beyond obviously the funding phase? Has the Ministry of Health been involved? Have they taken ownership? We just wanted a few more comments around that.
You wanted to know what other additional activities to this intervention?
So we just wanted to know about the sustainability. What is the plan for sustaining this process to the health authorities in Rwanda?
Yes, thank you for the question. After this intervention, we took 6 months of intervention of sustainability, where this model have been adopted by MOH leadership, hospital leadership and district leadership for adopting this model of implementation in terms of reduction of neonatal mortalities, because all leadership, either the district hospitals leadership and the local leadership participated in running collaborative sessions, and they own saw the result and appreciate the work, and then they decided to adopt this model, and it is going well as they accepted to adopt this model. So their midwives and their nurses continue to use national protocols, and the knowledge they gain during this intervention, they continue to do small scale-up training for to reach all maternity and neonatology staff. Yeah.
That's great.
Thank you.
Great. That's fantastic. I think healthcare providers, even in the most challenging settings, have good outcomes of whatever process. I think that in itself is often a motivator. So I thank you very much for that. And thank you very much to all the 4 speakers who are present for this session. We are very sorry for the technical problems, but we thank you for your patience in remaining engaged in it. So I'm just going to list them. So that was Marie-Louise Manirakiza, and then those Benjamin Black and Alison Shatter. So we thank you very much for all of you for your participation in this session, and I hope that there'll be more questions that will be able to respond to if you access them on your app. So thank you very much, and pleasure to meet you, and goodbye.